A very good morning, friends. Thanks, KSOS, for having me here. Thank you, Shaji, for including me in your instruction course. Shaji is an up and coming and a very dynamic, very brilliant, member of KSOS who has been doing exceptionally good work for KSOS at all fronts. So I'll be. Can the timer be switched on? So, yeah. So I'll be talking about commonly ignored issues in IL power calculation. So we all know it is cliche to say that cataract surgery today is like refractive surgery, and we want to hit the bullseye each and every time we take up a patient for cataract surgery. And for most of the cases, the holy grail is plano 6/6, though it could be any other target refraction. Now we need to have a benchmark, what we are aiming for in our practice. So this is actually a very comprehensive study published by Giacomo Savini, a good friend of mine from Italy. So it showed that with all the major formulas, current formulas, we should have 88% of your patient with Barrett Universal 2 to EVO 90.67% of your post-op refraction falling within a refractive prediction error of 0.5 diopter. So this is the direction that we want to move at. Beyond, this is our routine cases. I'm not talking about complex scenarios which will be dealt with by the subsequent speakers. And this is where we want to go. And maybe beyond that, it may not be very easy for us to further improve or fine-tune the results. So basically what I'd like to emphasize for the youngsters here, IL part calculation, most of the time it is something that, preoperatively you just tick the box. Yeah, it has been done, over. No. It encompasses the entire gamut of the surgical experience of the patient, spanning from the preoperative stage to the postoperative period. Now, we have already known that ocular surface plays a very important role in IL power calculation, and it has to be stabilized in case it is unstable. And if you do the biometric measurements on an unstable cornea with an ocular surface disease, it's quite possible that your keratometry reading will not be properly done. And as a result, even in your monofocal cases, you may land up with a residual refractive error. And for toric surgery, you may end up calculating the wrong axis and the wrong power. So the first thing first is, we always, for all cataract patients, rule out the presence of ocular surface disease. A diagnostic workup is done. And in case we have found that the ocular surface is deficient, the patient is put on tear substitutes to optimize the ocular surface, and the biometry is repeated every few weeks until we get 2 consecutive repeatable values. And I would like to emphasize on the nil touch technique of biometry. When you do the biometry, the cornea should be pristine, it should be virgin. It should not be done when we have put dilating drops on the patient's eye, anesthetic drops on the patient's eye, or Goldman applanation tonometry, gonioscopy has been done. Sometimes we end up doing it because of logistics reasons, but in such cases, it has to be explained to the patient that there could be we could miss the target refraction, and it is always important to bring the patient back on another day for the biometric workup. Many a time, right from my postgraduate days, I have realized that you need to dilate certain eyes for a better biometry. I'm talking about ultrasonic biometry, and this also holds true for optical biometry. Now, recently there was a study. This was using the IOL Master 700. It showed that 8.5%, 52% of cataract patients had very low quality biometric measurements because the cataract was dense. And once those cases were dilated, in almost 76% of the patients, the biometric values improved. So there is some role for pupillary dilatation in case you are not getting proper biometric measurements, even with the optical biometer. But then this brings us back to another experience of ours. That is, if you do the biometric measurements after the pupil is dilated, the measurements are altered. You get wrong parameter. You get different parameters. Central corneal thickness, anterior chamber depth, lens thickness, everything changes. And it has been shown that even if you use the latest formulas, Barrett Universal 2, Olsen, Hill RBF, Hygie's, almost 1/4 of the time you end up with a myopic result in post-operative period. So this has to be discussed with the patient when you take the consent from the patient. Sometimes we use tear substitutes before biometry. So in case you do that, please wait for at least 5 minutes before you do the keratometry for those patients. And again, this is a meta-analysis, a slide given to me by the late to high gaze, so it shows that, optical biometry is way superior even for, for ultrasonic biometry using the immersion mode. Even if you're using a optical biometer, please remember that the validation guidelines still work. If you get results which are tagged red, you may have to delete those results and repeat the findings, repeat the measurements. For hard cataract situations, some of those older optical biometers do not give any value. So this is what I do: right eye, left eye. So left eye, I could use the optical biometry, got a value. Ultrasonic biometry was done for both eyes. And then I look for a concordance of the optical biometry value and ultrasonic biometry value in the left eye, or sometimes if it's a pseudophakic eye. And if they're more or less similar, I know that biometric evaluation has been done properly, and it is again confirmed by repeat test. There are a lot of new formulas available. Many of these formulas do extremely well. My go-to formula is actually the Barrett Universal 2 formula. Barrett suite actually takes care of all your IOL requirements. So I would recommend that you start using this suite. It can even be used even if you have done an contact biometry for ultrasonic biometry. And asrs.org, this particular homepage gives you a lot of options. KN formula is the new kid in the block, so it gives better results for toric IOLs, for keratoconic IOLs, and there are a lot of studies. And for high range, extremes of eyes, small axial length, large axial length, I use multiple formulas and then take a decision appropriately. So friends, please remember that, before I forget, you can always make use of the second eye values to fine tune the results in the right eye. And preoperative measurements should be done on the naive cornea. Use validated measurements, work with properly optimized lens constants. Adapt to new technologies as they present. All new technologies are not the best, that is to be remembered. Employ the right formula and strive to use all available resources to their best advantage. Thank you so much for your attention.
Any clarifications or any doubts in the first presentation?
Others, thanks a lot for your
Thank you, sir.
hearing.
Thank you, sir. Thanks a lot.